A very warm welcome to the second episode of Pulmonology Read Aloud on IPF and PPF. My name is Dr. Anshamaneja Arora, and today we'll be talking about the term progressive pulmonary fibrosis and the INBUILD study on non IPF ILDs. If you haven't seen my previous video, you may click on the comment box link and go to the previous video which talks about IPF and its latest updates in the American Thoracic Society guidelines. So let's get started. Alright, so the term PPF means progressive pulmonary fibrosis, and progressive pulmonary fibrosis is typically defined as a non-IPF fibrosis that is worsening. So it's very simple to understand. It's basically an entity or any disease, ILD, where you know the etiology or you don't know the etiology like IPF, but it is not an IPF. So you haven't designated this as idiopathic pulmonary fibrosis, but this is progressing. Now progression is based on three things, and any of the two criteria, if they are met, then you can term it as a PPF ILD. So one is worsening of patient's symptoms, 2 is physiological evidence of progression, and 3 is the radiological evidence of progression. So this term's concept basically came after Flaherty et al. Actually published an article saying what's in the name, what we call IPF, by any other name would be the same. So basically, if it's a disease, if it's an ILD, whether it is HP or an occupational lung disease or any other form of ILD that is progressing in as bad a manner as IPF, then would you like to split it still into IPF and non-IPF and decide the therapy and the prognosis? Or would it not be better to clump them together to form a disease entity where we can give a similar management and have a good response? So this concept of not splitting IPF but rather lumping IPF with other fibrotic diseases came in the form of the term PF-ILD or progressively fibrosing ILDs, which was a huge umbrella term. Now in this PF-ILD, if you look, then these entities or the PPF entities are non-IPF diseases. And since we are talking only about the progression, so this term PPF is different from the umbrella of PF-ILDs. So amongst the PF-ILDs, you may get progressively fibrosing disease, and so it's not a diagnosis. It just talks about the progression of this entity. And how does this term come out is through multiple clinical trials. So still the criteria are not fixed or set based on any one study, but they believe that it would be helpful to term these patients as having PPF and give them antifibrotic therapy that you would give to an IPF. So this has very strong correlation with the prognosis and with the therapeutic. Now look at this very important flowchart. Now this flowchart tells you that other than idiopathic pulmonary fibrosis, there are so many other ILDs that can have a progressively fibrosing variant. So if you look closely, the blue shaded area here shows what is the role or what is the prevalence of progressively fibrosing disease in each of these entities. And something that really shines out is idiopathic NSIP, PPFE, AFOP or organizing pneumonias of fibrotic variant, the unclassifiable ones, the autoimmune ILDs, and the exposure-related ILDs along with sarcoidosis. So it's very important that we understand that even in these ILDs, there may be progressive entities, and so these progressive entities may be treated just like you treat the IPF. So this is a beautiful table which actually summarizes all of this and also lays down the histological patterns. So if you just remember these few, which are numerably 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and a few others. So these 10 entities would come into your umbrella of progressive pulmonary fibrosis. So you can remember these names and they'll be really important for you, because the moment you see these, you would actually look out for progression, and you look out for those patients where antifibrotic therapy may be useful. Coming to the physiological criteria, well, we've already discussed that it involves worsening. So worsening can really be defined physiologically in the form of lung functions mostly, right? So lung functions, they have defined two criteria. One is FVC more than 5%, and the other is DLCO, which is the corrected DLCO more than 10%. Now both of this has to happen within a year of follow-up. So you diagnose this patient and you check this patient within a year, and you notice that he is rapidly progressed, and these values have had an absolute decline. Now some may argue that why not give a change in FVC, why not give exacerbation as a physiological criteria, why not hospitalizations, can we use 6-minute walk test, we could also have used changes in the quality of life of patient. They actually can all be physiological criteria. But what this group did was they wanted evidence. So they extrapolated the data from the IPF studies, and they found out that most criteria with FVC and DLCO directly relate to mortality in IPF. So they said, let's use the absolute change because it will forecast a poorer outcome. And in context of all the other factors, there may be so many alterations based on the clinical setting. So hospitalization patterns or acute exacerbation causes, they can change, but something that may remain constant is the lung volume changes. So that's how these criteria were taken. The other very important criteria, as I said, are the radiological criteria. Now radiological criteria means worsening of the HRCT, right? So worsening of the HRCT could be your visual determination of worsening. It could be worsening in the form of the areas involved. So a lower lobe was involved and now the middle lobe is also involved. Or it could be in the form of newer findings. So you see newer tractional bronchiectasis areas. You see more ground glassing if it was a fibrotic NSIP. You see newer honeycombing, you see more volume loss, or sometimes it's just UIP and UIP now. So you know that this is typically worsening fibrosis. So these criteria can be radiologist assessment. These criteria could be computer, AI related. Your computer may have quantitatively helped you, or you could have used caliper. So all these things together, if they show worsening in an ear, you definitely know that this patient is fibrosing. Now look at these two examples. Let's say that this is your first patient who showed the upper appearance almost 4 years ago, and 4 years later when he comes to you, this patient has shown progression. Now typically if we talk about the definition so far, it says within a year this patient should have worsened. So should we call this as a progressive pulmonary fibrosis, and should we not call it? Well, the group does still call this as a progressive pulmonary fibrosis because they see definitive worsening and the patient is worsened. So what is the importance of this follow-up criteria? Is it 1 year or 2 year, or could have been more? This is still not very clear. But what is clear is that there is worsening, and at least within a year of follow-up, when you see that it's rapidly worsening, you definitely know that you need to treat him as vigorously as you would treat your IPF. And vis-a-vis, now this patient underwent a CT a year later, and you see honeycombing, which is now more exuberant in the lower lobes, and just from a subpleural line it has actually started progressing up. This definitely meets the criteria, and this patient has a PPF. So again, the context may be different. The guidelines have given both these examples. The CT images are from the guideline statement actually, and you would notice that this follow-up criteria is something that I think with time will become more and more clearer. But for now, they have definitely written that there should be no IPF. There should be evidence of fibrosis on the CT scan. So you cannot include just a GGO or a ground glass as this entity. There should have been fibrosis, and within the past year you should have seen 2 out of the 3 criteria, and you should have no alternate explanation for it. So whether it was infection related worsening in the CT, no, then in that case you may not call it a PPF. But you had no explanation, but within a year it worsened, then you will have this PPF definition. So that's something which summarizes all of it, and you could take a screenshot of this and it'll be really helpful. So as I said, the optimal interval for a follow-up is still unknown. They again have extrapolated data from various studies. So like from this scleroderma trial, they sought that 12 to 24 months you would actually repeat the HRCT, and that's when you would notice the changes. But should it be an annual thing? Should it be 24 months as in the INBUILD study that we'll study? It's still not fixed, but the criteria for progression are really fixed. So coming to the treatment basically now is the focus of all of this discussion, because why have they actually done this? They've done this to make sure that this patient who's fibrosing and progressively worsening receives antifibrotic therapy. So there are 2 antifibrotic therapies that we have, pirfenidone and nintedanib. They are both approved for IPF. So they've looked into pirfenidone and nintedanib and decided. So the first drug is pirfenidone, and now we all know that pirfenidone works brilliantly in IPF. It's a very valuable drug. We've used in so many patients with IPF, but with non-IPF ILD, somehow there's a distinction. And the distinction that they recommend is that they want more research, and the group has realized that there's still not enough safety data and efficacy data in non-IPF ILDs to recommend regular use of pirfenidone. And so they need this research not only in general for such fibrotic ILDs, but they also need it for specific types of non-IPF ILDs. Now, why is this difference? Now, one of the major trials that tried to establish this relationship and give pirfenidone the boost in non-IPF ILDs was the RELIEF trial. But unfortunately, the RELIEF trial was stopped interim and early because they did not have a good recruitment. They did not have patients recruiting so early. So they thought it is futile to keep continuing the trial, and let's just stop it and do an interim analysis. Well, that does not mean that the drug did not work, and what really is projected as a failure of pirfenidone may not be the case. You look at this trial, and it included 127 patients, 1-in-1 division into pirfenidone group and placebo group. And although it was prematurely stopped, the results were still encouraging. You still see an improvement in scores with pirfenidone group. You see a lesser number of exacerbations. You see lesser decline in lung function and improve overall patient scores. So pirfenidone may also be a good treatment for such patients, but we don't have the data yet. So the guidelines gave it away and said that until more research is available, they would not recommend it firsthand. But what they did recommend was the opponent of pirfenidone, which is nintedanib. And we all know that nintedanib, an oral intracellular tyrosine kinase inhibitor, is a drug that blocks the pathway of fibrogenesis. So now this has been recommended as the treatment in IPF alongside pirfenidone, and it has shown success. So they incorporated this drug in non-IPF ILDs, PPF ILDs, based on certain data. And the majority data came from this study, again done by Flaherty et al., which was the INBUILD trial. So if you're a postgraduate who's appearing for an exam, the INBUILD trial is a very important landmark study that you must know, because this is the one that caused the inclusion of nintedanib in the treatment pathways of non-IPF ILDs. So let's quickly go through and understand what this trial was. Now, if you go back to my previous slide where I talked about fibrotic ILDs or non-IPF fibrotic ILDs, you would remember that idiopathic NSIP, IIPs with autoimmune features, unclassifiable, rheumatoid arthritis ILD, systemic sclerosis ILD, and occupational exposure ILDs lead the show. So these were probably the group that this trial also looked into. And though in 2014 for UIP, IPF, nintedanib and pirfenidone both were approved, later on, once the census trial came in for connective tissue diseases, for systemic sclerosis ILD particular, and got approval in 2019, a lot of weightage was given to the role of nintedanib in other non-fibrotic ILDs. And census trial is also a very important trial, and maybe if you want a video on census trial results, please leave a comment in the comment box and I'll do that too. So nintedanib was studied in these progressive fibrosing ILDs. This was published in NEJM. It is an open access paper published in 2019. So they recruited around 663 patients with chronic fibrosing ILD amongst the classification that I just showed. It was a multinational, multi-center study, and they divided into 1:1 group. The primary endpoint was again FVC, our measure of annual rate of decline, and the secondary endpoint was time to acute exacerbation and time to death. So they looked at patients over 52 weeks, but what was really interesting about this trial, it continued to look at patients beyond that as an open label nintedanib. So patients were given the option to continue nintedanib open label after the end of 52 weeks. So we got more and more data after that. But initially 150 mg BD of nintedanib was compared to placebo. And when you look at the primary endpoints, you know that we are looking at decline in lung functions in two groups, the overall population and the UIP-like fibrotic pattern only. Now, the secondary endpoints were again the symptom score, the exacerbation, and death at almost a year. So the inclusion criteria included only adult ILDs that were definitely not IPF, and they had to show signs that they were fibrotic ILDs. So at least 10% was defined as that criteria, and they also had to show that they were still well preserved. So these patients had an FVC more than 45 and a DLCO at least 30 to 80% of predicted. Amongst these, another important criteria was that they should have been progressing. If they are not progressing, they would not be included in the study. And in the study, the distinction was that they included 24 months as the progression criteria, as against the 1 year, which is a part of the guideline. So, just like the guideline, they define progressive fibrosis as worsening, with these criteria to be met within 24 hours of screening. Either he will have an FVC more than 10% decline, or if it's 5 to 10, then there should be an HRCT change, or if it's 5 to 10 with worsened symptoms. So again, those two criteria as I mentioned, or CT worsening and the respiratory symptom worsening. And they excluded patients who were on multiple immunosuppressants. They excluded patients who had multiple other comorbidities, basically to remove the confounding factors. And once they had done that, they got their results. So if you look at the group that was a part of this study, majority were either HP or autoimmune ILDs or rheumatoid or SSC ILDs. The other group was idiopathic NSIP and unclassifiable IPs. So amongst this group, they found that patients who were given nintedanib had a lesser decline in annual FVC, they had lesser ILD progression, and they had lesser exacerbations. And even in groups which were the overall group or group with UIP-like pattern, they saw a significant improvement in the FVC decline. So almost 57% reduction of decline in FVC in overall group, and amongst UIP-like pattern group, 61%. Now that means almost 3/4 of your patients will not have a decline in FVC over a year. And that was a huge response amongst both patients who had UIP-like pattern and even other patterns, because almost 49%, almost half of the patients did not have significant FVC decline more than 10%. So this was a very remarkable feature, and based on this and also based on reduction in time to acute exacerbation, they recommended that nintedanib causes lesser death, lesser acute exacerbations, and lesser decline in FVC, with quite comparable side effects to placebo, mostly being diarrhea. So they said that since Since diarrhea was a common major adverse effect which was well tolerated, this drug could be used safely in non-IPF fibrotic ILDs. So if you look at the summary, it looked really at a heterogeneous population of non-fibrotic ILDs. It did show unequivocally good results, but the problem is, the question here is that will it matter if these are UIP-like IPF ILDs or non-UIP-like ILDs with fibrosis? Well, they did show improvement in both the groups. Will it matter if we give this drug in an acute exacerbation of IPF and not in an acute exacerbation but in another patient? So will that matter? And will we be able to maintain the tolerability and efficacy beyond this 52-week group on a long-term basis? And does that mean that now we can cover all our fibrotic ILDs in one big blanket and give nintedanib to all? Well, that is a bit difficult to swallow. So definitely there are flaws to this study as well, but overall proven to be a very good study, and maybe a lot of more research is needed. And this slide tells you about my views and my opinions on what are the points for future research. So this really has to be looked into, and once it's done, maybe we can have more and more therapeutic options for non-IPF fibrotic ILDs. So that is the INBUILD study for you, and that is PPF for you. So till we meet next time, my dear friends, happy reading and enjoy. Bye-bye.